Good morning, good afternoon, good evening. I would like to give a warm welcome to all our friends around the world and thank you for joining our first webinar in our series of EFP Perio Sessions. I am Nicola West and I have the privilege not only of being the Secretary General of the EFP, but also your host for today. I would first like to say that the unprecedented situation created by the COVID-19 pandemic is a challenge for us all. The EFP sends its support and good wishes to all members of its affiliated national societies, to its partners, and to the dental community as a whole. We will come through this together and stronger. Today, the EFP launches Perio Sessions, a new concept for the EFP, delivering live, interactive webinars with a plethora of our top experts for you to enjoy on cutting-edge periodontal and dental implant topics, promoting education and awareness of periodontal science, supporting the EFP's guiding vision of periodontal health for a better life. The first webinar is presented by our esteemed colleague, Professor Anton Sculean. But before I introduce Tony, I would just like to explain how this webinar will work. Our speaker will present for approximately 30 minutes, followed by 15 minutes question time. The questions can be asked via the control panel on your screen. I will collate the questions and then present them to Tony. Due to the large number of attendees, we had a sellout in 5 hours. It was amazing. And the short time we have available together today, it will be impossible to answer everyone's question, but we will do our best to answer as many as we can. Now to the event we've so been looking forward to. Professor Anton Sculean is a world-famous periodontist and EFP statesman, well known to us all. Tony was EFP president from 2018 to 2019 and is professor and chair of the Department of Periodontology and executive director of the School of Dental Medicine at the University of Bern in Switzerland. Tony is a world-renowned researcher and clinician in the field of periodontology, with more than 370 peer-reviewed scientific articles. Tony also did an amazing job delivering the EFP Perio Masterclass in Dublin this year and has recently been awarded the prestigious IDR 2020 Distinguished Scientist Award for Research in Periodontal Disease on account of his significant contribution to the field of oral health research. It now gives me great pleasure to introduce my dear friend, Professor Anton Sculean, to give his presentation on the Bernese concept for the treatment of single and multiple gingival recessions. Over to you, Tony.
Thank you, Nicola. I'm just trying to. Okay. So, dear colleagues, dear Nicola, thank you very much for inviting me to present on behalf of the EFP. It's a great honor for me. And I would like to share with you some thoughts about the concept on treated single and multiple gingival recessions. And in my talk, I will follow some topics that you can see on the screen. First of all, the indication for treatment, our goals, some of the factors that may influence the outcomes, and then I would like to share with you our concept that we have developed during the last 15 years. And my cases very often are similar to those you see on the screen. Patients without sufficient attached gingiva, patients that have problems in cleaning, and they have, in fact, attachment loss, bone loss, and sometimes the problem is advancing over time, is progressing until the apex in certain cases. And please observe some examples. Patients without lack of attached gingiva, plaque accumulation, and pocket formation. especially if the case is coupled with some factors that may traumatize the hard and soft tissues. And in some cases, we may also face tooth loss. So for me as a periodontist, it is very important to ensure periodontal health. And it is obvious that if we are able to restore the soft and hard tissues surrounding the tooth, the patient has an easier task to clean. For me as a clinician, the most important goal is to help the patient to clean and to prevent gingivitis and root caries. Aesthetics are of course important, but this is secondary. Of course, in the upper jaw, this may be a case, but many cases, many situations, we have the problem in the mandibular arch. Please have a look to different indications, a case showing a deep recession in the mandibular area. Obviously, the patient has difficulties to clean. You can clearly see the gingivitis. However, if you are talking about maxillary arch, the indication is rather the improvement of aesthetics. And of course, before we treat, it is very important to try to find out what was the cause of the problem. Was it a mechanical trauma? Was it periodontitis? Was it maybe an orthodontic therapy or a combination of different factors? Sometimes we may face situations with trauma like piercings, and this may also cause loss of soft and hard tissue. The goals of the treatment are very simple. First of all, we help the patient to clean. I would like also to restore completely the lost tissues, but also to avoid niches, to avoid residual pockets, a pocket depth extending 3 millimeters. For this reason, we would like to enhance periodontal regeneration in many cases, but also to enhance a nice tissue blending and color by avoiding scar tissue formation. And please have a look at the patient after about 5 years of following the treatment, and we can clearly see a very nice contour of the soft tissues. Of course, we have to deal with the patient, with the anatomical factors, patient-related factors like smoking, general diseases, biofilm control, but also the surgical technique. And if I would now focus on the surgical technique, in our philosophy, the most important is to focus on the biology. In other words, I would like to help the wound to heal because the wound healing process, especially during the first 2 and 3 weeks, are of critical importance for the healing. For this reason, we would like to accomplish periodontal regeneration involving formation of cementum, periodontal ligament, and bone, as you can clearly observe on this histologic image. And we may use some biologic factors in conjunction with our surgical technique, and we can use, for example, enamel-matrix proteins or maybe some other biologic factors like hyaluronic acid. And let me show you some biologic backgrounds, because I think this is very important to understand the philosophy. If we would look at these cases, more than 20 years ago, we performed regenerative surgery in recession type defects using enamel-matrix proteins, and we were able to demonstrate formation of periodontal ligament and root cementum on these surfaces. Later on, we combined enamel-matrix proteins with connective tissue grafts in order to enhance wound stability and keratinization. And you can see here an animal study depicting 2 different groups, one test and one control. The control involved only the placement of a connective tissue graft, whereas the test also the placement of enamel-matrix proteins. Here you can see the clinical procedure involving the placement of the connective tissue graft combined with enamel-matrix proteins. And if you look now at the clinical measurements, you can clearly observe that in the test group, the probing depth was about 1 millimeter less compared to the control one. And the histologic analysis demonstrated clearly some regeneration in the control group, However, in the test group, we had significantly higher amounts of new cementum, periodontal ligament, and bone, indicating a favorable biological condition. And if you look now at this table, you can clearly see the length of the epithelium that is shallower in the test group compared to the control one, and also the formation of cementum, periodontal ligament, and bone significantly higher in the test compared to the control one. Another biologic factor that we may use is the hyaluronic acid. And these are, dear colleagues, some new data, unpublished yet. And we used this material in conjunction with a coronal advanced flap. And the hypothesis was to see whether with this material we can improve periodontal wound healing and regeneration. And in this particular study, we use a coronal advanced flap with or without the application of hyaluronic acid. And if you have a look at the control side, you see a very little regeneration of periodontal ligament, cementum, and bone, whereas in the test side, the periodontal regeneration involving all three structures was significantly higher compared to the control one. And also, the histometric measurements revealed significantly higher formation of cementum compared to the control one if you look at the test group. This means that with these materials, we may additionally enhance the biology of periodontal wound healing and regeneration. So the concept is that we would like to stabilize the wound by avoiding vertical releasing incisions as much as possible, use of biologic materials, as you have seen before, in order to enhance periodontal wound healing and regeneration. And due to the fact that in the most cases, the tissue is very thin, we would like to use some materials, preferably autogenous tissue, that may additionally stabilize the wound and enhance soft tissue thickness. And of course, the surgical technique involving flap adaptation and suturing are mandatory. So our concept is very simple. We look first at the thickness of the tissue, the so-called phenotype. And if the thin tissue is less than 1 millimeter, we need to increase the tissue thickness by using a graft, for example. And it is very important to look at this factor because if the tissue is very thin, as you can see it in this slide, we need to increase the thickness by using a graft. And we worked over the years at the modification of the coronal advancement of the tunnel. Why? Because we have a very good wound stability, very good wound vascularization, and a nice increase in tissue thickness and tissue blending. And of course, for this procedure, we need specially designed instrument, so-called tunneling instruments. And let me show you some cases. In the upper jaw, if we have a thin tissue, we prepare first a full thickness flap, preserving the papilla, then we move the flap into an apical direction, dissecting the inserting fibers and moving the flap coronally without any type of vertical releasing incision, stabilizing the flap and the papilla with a connective tissue graft, and suturing in an atraumatic way. Please observe the outcome after a couple of years, indicating a very nice and pleasant outcome. What about lower jaw cases? If we have a recession, as you can see it on this slide, again, we start with the preparation of a full thickness flap, moving the tissue coronally without tension, stabilizing the tissue with a soft tissue graft, and please observe the outcome after 4 years. Meanwhile, I have treated more than 950 cases during the last 11 years, and we have a very good material that will be published soon. The mean root coverage amounted with this technique more than 90%, 96%, which was very, very positive, especially in lower jaw cases. However, in certain cases, we may face the problem of a coronal movement of the flap, especially in deep mandibular defects. And for this, indication we developed together with my esteemed colleague and friend, Dr. Pat Allen from Texas, the so-called laterally closed tunnel. It has certain advantages. First of all, we don't have vertical releasing incisions. Secondly, we have very good wound stability, and we do not decrease or only very little decrease the depth of the vestibulum. Please have a look at some cases. In this particular case, it would be very difficult to move the soft tissue coronally. So if we face such a case, we prepare the flap. We extend it mesially and distally, but we dissect the inserting fibers in order to allow for a tension-free adaptation of the soft tissues. And instead of suturing the flap coronally, we suture it laterally with single interrupted sutures. And please have a look at the outcome in this particular case at 3 years following the treatment. Another case, the comparable situation, and please observe that the majority of my cases are lower jaw cases, and here the aesthetic outcome is not as important as the health of the periodontium. Again, the same procedure. Please observe the steps, quite easy to perform if we train it, and we have a very nice and stable outcome, 100% coverage in this case after a couple of years. And this case was even more challenging, about 10 millimeter recession depth associated with a pocket of about 4 millimeters, so total of 14 millimeters attachment loss. And it is a very, very wide recession. And a couple of years ago, it was simply impossible to cover such a defect in one single surgical session. So what we perform is an intrasulcular incision with a microblade, followed by preparation of a full thickness tunnel. Please observe that the tissue is very thin. And this is the reason why I perform a full thickness approach, at least at the beginning, until we pass the mucogingival line, because otherwise we may face the problem of a far too thin tissue covering the defect, implying automatically a higher chance for tissue necrosis. And we may also have a perforation of the flap. For this reason, it is very important on how we move the blade. The blade has to be in contact with the soft tissue. And eventually, in some cases, if we feel a tension of the lips, we may need to go deeper with the preparation and dissect also some of the inserting muscle fibers. Please observe that in this particular case, the attachment loss reached also the apex. So for this reason, I always use in these advanced cases a regenerative material, one of the materials that I have listed and demonstrated to promote regeneration in the studies before. Of course, it is very important to use the soft tissue graft, and my preference goes for autogenous tissue because we have certain advantages. The autogenous tissue from the palate provides the biologic information for the keratinization process, contains growth factors and living cells. And a big advantage is that in cases where we are not able to completely close and submerge the graft, we may still have a very good outcome, provided that we can submerge about 2/3 of the graft. Please observe the suturing technique, which starts apically. We need to have short needles in order to better control the steps of the suturing process. And we simply use interrupted sutures, making sure that we are not touching with the tip of the needle the graft. And please observe the stability of the graft. In this case, I would like to show you also the result. And please observe a complete root coverage, very nice color, and the probing depth is about 1 millimeter. In other words, we have about 30 millimeters of new connective tissue attachment. And please observe the results that we have published together with my friend Dr. Allen, which are excellent, especially in these very challenging situations. How do we go on in multiple cases? And we have a number of systematic reviews that have looked at the techniques that we can use. And the two techniques very widely used in the literature and very well documented is the technique described by Anton Sculean and his co-workers, and the modifications of the coronally advanced tunnel. Please let me allow to share with you some cases. This patient was treated by me about 10 years ago, more than 10 years ago. I always document every single step, cleaning the root surface, the incisions. The technique is in fact the same as you have seen before, but we prepare the flap, we extend the flap more apically, more mesially, more distally, in order to allow a very nice coverage of the soft tissue graft. And please observe the soft tissue graft covered completely, the outcome after about 2 years in this particular case. And if we follow up after about 7 years, 8 years, 9 years, the results are very stable. Please observe another case indicating a stability of the situation after 9 years. And we also published the 1-year results. Now we are going to publish the long-term data, and the cases in the maxillary arch work very predictable as well. What about if we have multiple mandibular cases, as you can see it here? This is a nurse from the hospital with very, very thin tissue, multiple inserting frenula. And nowadays, I do not perform any longer a frenulectomy before the surgery, but I prepare the tunnel and have a so-called internal frenulectomy. And then with a soft tissue graft harvested from the palate, of course, we need to have a long graft. This is a palato-tuberal graft. We stabilize the papillae, and then the closure is a mixture between a coronal advancement and the lateral closure of the flap. Please observe in this challenging case a very nice and stable outcome at 2 years following surgery, and you can clearly observe 100% coverage in all treated recessions. This is another case, a patient that was treated with composite fillings. And of course, if you always renew the fillings, then you will damage the soft tissue, and this will result, in fact, in a further deterioration of the situation. Please allow me to share with you this video. This patient was treated by me about 3 years ago, and the composite fillings have been removed, intrasulcular incision placed, and this is the so-called internal frenulectomy, which needs to be carefully executed in order to have a complete release of the fibers. The big advantage of this technique, especially in the lower jaw, relies on the fact that we do not cut the papilla. The papillae. This is very important because the papillae will stabilize the entire complex. And then, of course, we need a soft tissue graft. If we have, as in this case, for example, more than 6 recessions, I start my incision distally from the last molar, and I use the technique described by Ellen and Rolenzana and Wenger and Hürzeler by keeping the blade in parallel to the epithelium. And in this way, I have connective tissue graft that is harvested from the close vicinity to the epithelial surface. The thickness of the soft tissue graft is of about 1 to 1.5 millimeters, and this connective tissue graft has the growth factors necessary for the wound healing, has living cells, and also a certain potential to influence the keratinization process. It is though very important to carefully analyze the anatomy of the palate, because we may face situations with a shallow palate or situations with a kind of high palate. And the palatal artery is always closer to the teeth when we face a situation as in this video, a situation with a shallow palate. I like to use this technique because I can close it. And if I can ensure complete closure, the patient has less difficulty during the healing process. It is more comfortable, and we can even harvest a second time after about 6 months a new graft from exactly the same area, of course, only if it is needed. Please observe the connective tissue graft, and I always adapt the graft and fix it in a way to stabilize especially the central papillae, because this is in fact the most important area of this multiple recession zone, because the central papillae are responsible for the stabilization of the anterior area. And then, of course, we need a very well-trained assistant that is going to help us at the steps, pulling the graft into the tunnel, because this is very technical sensitive. And of course, all the steps, all the previous steps need to have been performed very, very carefully in order not to stop the connective tissue graft. In other words, we need to completely detach the fibers from the underlying surface or from the surface of the flap. The next step is to fix the graft. I like to fix the graft at one end because this will create a stable point. And then I can stretch the graft to the other end. This is very, very important in order to allow good stability of the graft. And then with very simple sutures, these are so-called sling sutures, we just pull the graft coronally and fix the graft exactly at the cemento-enamel junction. And if I face several deep recessions, as you can see it in this particular case, I like to use single sling sutures because this will give me an additional stability of the entire complex. And once the graft is fixed at the cemento-enamel junction, we need to close completely the graft and to close, of course, the recessions. So please observe we are facing different types of recessions. We have some recessions that are very, very deep. Some others are a little bit shallower. And in these cases, I alternate the sutures. A lateral closure is going to be combined with a coronal movement of the tissues. And this will allow for a very stable healing, very stable situation in the operated area without substantially changing the depth of the vestibulum. So this is, in fact, the technique that we use for these challenging cases. And please observe that the papillae are not cut. Now we have complete coverage in this particular case after 2 years. Please let me show you some new thoughts. How do we address treatment of multiple lingual defects? This has not been yet reported in the literature. Very difficult to access. This is one case that was sent to me by my friends from the orthodontic department, from Professor Katsaros. We work together very close. And we have here a situation after completion of the orthodontic therapy where the patient had difficulties to clean. This is the indication in these particular situations. And I try to implement the modification of the tunnel approach also lingually. And here I prepare the tunnel. Of course, the surgical access is far more difficult. Tunnel from canine to canine. We need to stay on the bone. Don't use the blade in order not to hurt or to disrupt any blood vessels. And of course, we need an autogenous tissue. that is going to be fixed laterally and coronally. And please observe in this particular case a complete coverage in almost all recessions. And of course, the main indication here was to help the patient to clean and to ensure long-term stability. Another case, please have a look at this particular situation, a patient after orthodontic therapy with an active retainer. This is very important to detect, because if we have an active retainer, we need to redo the orthodontic therapy. So we have to work in a team. Please observe this particular situation with the frontal teeth in a different position, probably due to the active twisted retainer. In this case, I always work together with the orthodontic department. In some cases, we need maybe even 6 to 9 months to move the teeth back into the bony envelope. And please observe that just by this movement, we have a very good improvement of the situation. So in other words, we need to diagnose first and then to work in a team. This is extremely important if you want to obtain a very good and predictable outcome. This particular case, again, after completion of the orthodontic treatment, I performed a lateral move tunnel, here in conjunction with the application of hyaluronic acid, which is very hydrophilic and stabilizes the blood clot, and of course combined with the autogenous tissue, because this is now my first graft that I use in these challenging cases. This is the material of choice. Then almost complete closure associated with a very good healing after about 1 year. Please observe that the patient can clean much better. We have a very nice aesthetic outcome and 100% coverage in this challenging case that involved about 8 millimeters of recession depth. So let me come to some conclusions. They are very simple. For successful outcomes is, in my opinion, an interdisciplinary approach, very, very important. And of course, the main goal is to obtain periodontal health. I hope that I was able to convince you that our techniques are predictable surgical approaches for both single and multiple defects, not only in the maxillary arch, but particularly also in the mandibular area. And the use of certain biologic materials like enamel matrix proteins, hyaluronic acid, but maybe also some other materials that will emerge in the future, may have a positive influence on soft tissue, wound healing, and regeneration. And thank you very much again for listening to this webinar, for inviting me to share with you this first webinar. And I am ready to answer your questions. Thank you very much.
Thank you, Tony. A fantastic, flawless presentation as always. Your surgical skills are amazing, as demonstrated by that clinical footage. And I was really interested to see your surgery in the lingual area. It looks very predictable. Thank you. You're inspirational. Let's now answer questions. Any questions from our viewers? If you'd like to type them into the box, then we can ask Tony. While we're waiting for those questions to come in, Tony, what post-op instructions would you give your patients?
This is a very important point. It is very important, first of all, to have clear instruction, to give clear instruction for the patient. First of all, not to touch the operated area, not to move the lips, not to look in the mirror 20 times a day to look whether the graft is still there, because this may affect the stability of the wound. I give the patient some instructions to start brushing with a very soft brush after about 1 week. If the graft is exposed, no chlorhexidine rinses in order not to have a negative effect on the exposed surfaces. However, if I'm able to completely cover the graft, then they will rinse the day after the surgery with chlorhexidine. I also give, of course, routine painkillers, ibuprofen, but also in the first day, we like to give corticosteroids, dexamethasone, 4 milligrams a day. We can also give 4 milligrams twice a day, or sometimes one single shot, but not longer than 1 day, because this will help the swelling, to reduce the swelling, and also the patient comfort. If the surgery was very long, sometimes, as you have seen it in the last video, it involved about 8 teeth, and it takes longer time. Then, in order to ensure infection-free healing environment, we give for a couple of days antibiotics in order to prevent infection. And in these particular cases, we give amoxicillin about 2 grams a day for a period of about 5 days. The sutures will be removed usually after 2 or 3 weeks. I prefer nowadays, especially in difficult cases in the lower jaw, to keep the sutures a little bit longer, even 3 weeks. Nothing will happen since we work with monofilm material, and there the plaque accumulation is quite limited, and the soft tissue healing is very nice.
Tony, that was very comprehensive. I think a lot of people will be very grateful for that answer, to tell us, the bits behind the surgery that we don't always hear. Thank you.
Yeah.
Any other questions coming in from the audience? If you type them into the box, we can then ask Tony. I was also interested, Tony, in the way you stabilized the graft around the central papilla. I think that's a very useful comment to make for people trying this surgical technique.
Yeah, I mean, this was always my thought, that because I have also tried the coronal advanced flap, but if you are working in especially in the mandibular area, and we have this very, very thin tissue, sometimes it's like a paper, and if I cut the papillae, especially the central one, then I have real difficulties in suturing it afterwards. It takes longer time, and you will never have the same stability of your flap than without cutting the papilla. And this is, in fact, one thought that I had, and we try to develop it together with Dr. Allen, and it seems that is a biologic background behind. Everything is biology. In fact, with this technique, we don't do anything else but helping the wound to heal, helping the area to heal by itself. Everything what we do is helping the body to heal by our surgical flap preparation, by keeping the papillae. We don't disrupt the vascularity, by having the graft that is stabilizing the blood clot, increasing the thickness of the flap, of course also providing some growth factors and cells, and also the tension-free sutures that will cover in an atraumatic way the graft and the recession. So in everything what we do, we think at biology, and if we can help the body to heal, then the outcomes will be excellent. It's not very complicated.
Thank you, Tony. You have an expert pair of hands. So, with someone like yourself, we can see fantastic results. Thank you. Tony, it gives me enormous pleasure to thank you for sharing your time and your knowledge with us today. I'm sure we'd all like to give you a rapturous virtual applause. So what do we have in store for you next week? We have Filippo Graziani. We will all look forward to joining you next Thursday, the 23rd of April at 5 o'clock Central European Time for our second EFP Perio session. Filippo is very well renowned, and I'm sure you all know him. He will be presenting on periodontal surgery of complex defects, not to be missed. We wish you all stay safe, stay healthy, stay home, save lives. Thank you for your company today, and good wishes to you, your family, and to your friends.